A warm good evening to all our followers on Facebook. Welcome to this webinar. On behalf of Times of India and Emerson Laboratories, we invite you to join us as we commemorate World Pulmonary Hypertension Day on this day, May 5th, 2023. This day is commemorated with the sole purpose to raise awareness of this frequently misdiagnosed disease, which is pulmonary hypertension. To understand more about pulmonary hypertension and its management, we have here with us today an expert panel of doctors. Without any further ado, I'd like to introduce them to you. I'll begin with Dr. B.C. Kalmat, MD, DM, DNB Cardiology, Professor of Cardiology at Mumbai Hospital, and Senior Intervention Cardiologist at Jupiter and Horizon Hotels, Thane. Dr. Kalmat, welcome.
Thank you.
Dr. Kunal Praful Sinkar, MBBS DNB Medicine, MNAMS DNB Cardiology, with a fellowship in structural heart intervention from Italy and currently associated with the Holy Family Hospital, Breach Candy Hospital, Saifi Hospital, and Asian Heart Institute, Mumbai.
Thank you.
Dr. Alpa Dalal, MD Chest, DNB, Head of Department of Pulmonary Medicine at Jupiter Hospital, Thane, and Nodal Chairman for the Drug-Resistant TB Unit at the Shiori TB Hospital. Dr. Amit Gawande, MBBS, DTCD, FCCP USA, Consultant Interventional Pulmonologist, Mumbai. And Dr. Harish Shafle, MBBS, DTCD, DNB, Respiratory Medicine, IDCCM, Senior Consultant Intensivist, Physician, Bronchoscopist, and Sleep Disorder Specialist, Mumbai. Doctors, you must commend me. That was a mouthful indeed, just getting all your designations and all your, all your professional qualifications right. And on that right note, let's begin right away. Dr. Kalmat, I'm going to start with you.
Thank you.
Let's start at the very beginning. What exactly is pulmonary hypertension?
Thank you, Mary. It's been a pleasure to be on the dais with so many of my good friends on the Pulmonary Hypertension Day celebrated by Times of India and MSN. At the outset, I thank both of them. And pulmonary hypertension is just like we have essential hypertension, what you call the daily basis on the periodic side, where you see, well, commonly we think about when you say hypertension, it is essential hypertension, what you feel. In pulmonary hypertension is the higher pressures seen in the pulmonary circulation, that is on the lung sides. That's why I have a lot of my chest faculty, the pulmonology faculty with me today. So whenever the normal pulmonary high pressures are below 25 to 30 milli of mercury, whenever somebody is born, the pulmonary hypertension is high. Within few weeks, they normalize because that's what is the normal physiology. But when the pulmonary artery pressures rise due to any causes, the causes may be due to structural or pulmonary vascular disease or pulmonary parenchymal disease or due to heart disease. Many of the obstructive, the valve disease, commonly the mattress stenosis in India, and many of the other left-hearted diseases can cause higher back pressure into pulmonary circulation because that's how heart and lung is involved, makes the secondary pulmonary hypertension. But there is something called as primary pulmonary hypertension, which generally has no cause, which is detected easily. That's why we should remember when we say pulmonary hypertension, whether it is secondary due to lungs or lung disorder or lung arteries or due to heart, or sometimes rarely a very appalling condition called as primary pulmonary hypertension, where generally we don't have any cause because the pulmonary artery pressure gradually increases and the patient starts complaining of breathlessness, fatigue, and hypoxia and heart failure. That's what, in a nutshell, is pulmonary hypertension, which is the higher pressures on the pulmonary side. Mary.
Thank you, doctor. Just one more question that I want to ask you. The moment we hear the word hypertension, there's a completely different connotation that all of us lay people put to it. So could you tell us what's the actual difference between the two, especially by highlighting the difference?
Exactly. The normal hypertension, whenever we say is the essential hypertension, wherein people, there are few millions of patients in India and world over, more than 120, 40 million people suffering from hypertension, what is commonly, which is measured by sphygmomanometer or on the arm BP, what we call, which is related to the aorta and the other arteries which emerge from the left heart. That's what is commonly is hypertension, which leads to brain strokes, myocardial infarction, and kidney failures, which is the common cause for brain hemorrhage, strokes, or heart attacks, or the kidney failure, which is the common connotation. That's very, very common. Actually, the prevalence is more than 8 to 12% in our Indian scenario. But the pulmonary hypertension, you cannot measure it by putting somebody's pressure apparatus on the arm, or that has to be measured by echo or a cardiac cath from the pulmonary side, that is the right heart side. The right heart has pulmonary arteries which are always going to the lungs, whereas the left heart has the aorta and the brachial arteries going to the limbs. There you can measure the pressure in the arm or on the leg, unlike the pulmonary arteries are never palpable or never seen outside or never palpable. That has to be measured by echocardiography or a MRI or sometimes a cardiac cath. Cardiac cath means the angiographic cardiac cath. That's how the big difference is made.
Thank you, Dr. Kalmat. I think we'll also get to that in the subsequent questions. Dr. Kunal, can you tell us how common exactly is PH? And, I'd like to add one more bit to that, which is who exactly is at risk to get this?
So pulmonary arterial hypertension is quite common. Around 10% we can see in elderly above 65 years. But whatever we see, all my colleagues will always agree with it. We see only the tip of the iceberg. There are a lot of patients which are undiagnosed with pulmonary artery hypertension. So to diagnose pulmonary artery hypertension, there is a proper clinical, you have to see the clinical profile of the patient, do some tests like echocardiography, and as Kalmat sir rightly said, right heart catheterization to see the pulmonary artery pressures. So next question to be answered, that who all are at a high risk. The first important thing is obesity. The obesity can cause sleep disorder, sleep apnea, which we say they can cause pulmonary artery hypertension. Then we have drug users. Then some patients are taking some drugs for reducing their weight, appetites. They can cause, like fenfluramine drug can cause pulmonary artery hypertension. Those who stay at high altitude are at a high risk for developing pulmonary artery hypertension. And one also should be mentioned, the patients who are having congenital heart disease like ventricular septal defect, ASDs, at a later date, the natural history of the disease, they will develop pulmonary artery hypertension. But as rightly said, Kalmat sir said that primary pulmonary artery hypertension, which is idiopathic, which is we don't have any cause for that, and that is very difficult to treat. So we have to first find out the cause and then treat accordingly.
Thank you, Dr. Kunal. Dr. Alpa, can we now discuss another aspect, which is pulmonary hypertension hereditary? Or is there any specific reason for this happening? Doctor, you're on mute, please.
Yeah, so as just Dr. Kunal had described, that there are various etiology of pulmonary hypertension. So the first and the most important thing is that just when you come to know that you have pulmonary hypertension does not mean it's going to be hereditary. So you have to rule out all other causes. Like he said, the cause could be in the heart. If your heart function is low, if your heart pumping is less, or if you have congenital heart disease, then you have pulmonary hypertension. That is not hereditary. If you have it because of lung conditions like having a COPD or having obstructive sleep apnea, so even that is not hereditary. So a subset of pulmonary hypertension, which was just described, it is called idiopathic pulmonary hypertension or primary pulmonary hypertension. There, of course, few of these patients, not all of these patients, but few of these patients do have hereditary pulmonary hypertension. And these are the patients where when we diagnose them with pulmonary hypertension, we advise their close relatives to be screened for presence of pulmonary hypertension. And at times we have picked up, in the sibling or in their distant cousins, we have picked up pulmonary hypertension at early stage, and that really helps to get them treated early.
Thank you, Doctor. I think it's very important for everybody to know these aspects of it. Dr. Amit, could we now dwell in a little more detail on what are the factors that can cause or contribute to pulmonary hypertension? And also, my next part of the question will be, what are the symptoms exactly of pulmonary hypertension? I just have a small request to all the doctors. Please don't worry if you feel you're repeating a point, because it always merits being repeated, because there's no way we can say when our audiences join in and start listening to us. So Dr. Amit, over to you.
Yes, right. Thank you, Mary. First of all, I'd like to thank Times of India for actually conducting this event and making people aware of such a disease, which unfortunately is rising in the world. And we all need to know about this, and because there are many ways we can help ourselves from preventing it. Now, to answer your question, the usual factors or the causes of this disease, that's a very long list, but I would just summarize them into certain parts. So, first is you need to find the cause of pulmonary hypertension. Pulmonary hypertension, in many reasons or in many cases, is consequential, and in many cases, it comes as primary, as all my colleagues and seniors have explained that if it is primary, that means there is no cause of it. It is just absolutely of no cause. That is why it is called idiopathic. Then there comes options like heritable, or that it comes through genetic mutation. Then there is other causes. Now, I want to divulge them into two different factors for the general public to understand. Factors which you can influence and factors which you cannot influence. So there are factors that you can influence directly or indirectly. For example, if there are for example, as we all know, as everybody has told you before, there are certain heart diseases that do cause, as a consequence, they cause pulmonary hypertension. Now, heart diseases per se can be hereditary congenital or can also be because of our lifestyle. So, a good change in lifestyle can definitely be a cause of pulmonary hypertension, or by indirect method of having a heart disease. Second could be the lung. If you have a lung disease, some lung diseases are generally caused by us. For example, a COPD, which is because if you're smoking or certain pollutions or inhalation defects, which can cause COPD. Hence, eventually, it will cause a pulmonary hypertension. So, if we stay away from these habits, it can definitely help us not getting into a pulmonary hypertension scenario. But then there are certain causes which are not in our control. For example, as everybody said, idiopathic, where you don't know what the cause is. Then there is heritable, which again is not in your control. Then there is some diffuse lung diseases, for example, ILD, which again can most likely are not in your control. But there are again diseases which can be controlled, like everybody mentioned recently, sleep apnea. Sleep apnea is a disease most likely caused to obese people. So obesity in turn can cause PAH in indirect manner. So again, something that can be correctable by people. So I think we could just assimilate them into factors which we can correct and which we cannot correct, is what we should remember as people, that there are certain factors like having a good lifestyle, having a good diet, staying away from chronic habits, and having a good exercise regimen, having low salt intake. These are the factors that can help you not get into a serious scenario like pulmonary hypertension. But the other scenarios are something that I don't think any of us have any much control over. So I don't think there is something that as general public we should worry about, because that is not in our control. We have to just worry about the things that are in our control. Now, to get into the second phase of your question, that is, what are the signs and symptoms? These signs and symptoms can be differentiated into two different types. That is the earlier signs and the much later signs. The earlier sign is, for example, the reason why pulmonary hypertension is not very well diagnosed or very early diagnosed is because the signs are very vague. So the symptoms are very vague. The symptoms, for example, the most common symptom is fatigue. Most patients will come to you, or if they do in the early part of the disease, they do come to you, fatigue syndrome. That is, they're just tired all the time. Then there is sometimes they will come to you with mild dyspnea, there is mild breathlessness over long hours. Working for long hours makes them breathless. They can also come to you sometimes with mild palpitation, that is, they are feeling that their heart rate has increased. Now, most of the times, most of these patients do not end up coming to a pulmonologist or a cardiologist. They end up going to physicians and somehow get overread by certain medications. Hence, it is very, and unfortunately, it is very widely misdiagnosed or undiagnosed. Then these are your most common symptoms that you will come with. Then there are many other symptoms that patients might have. If it is a heart-related pulmonary hypertension, patient might have pedal edema, that is swelling on the legs. They might have weight gain. They might have sometimes what we call as a dyspnea when we bend forward, for example. That is also very common in these patients. These are your early signs. Now, if you can, or I would rather say that everybody should take care of these signs and should be more vigilant towards these signs. If you ever lose or don't realize these signs, then the later signs are that the dyspnea is very severe. Even a little bit of walk can make you dyspneic or
Yeah,
breathless.
we'll get there, Doctor. I'm going to interrupt you and say we'll
Sure.
get there to those questions because we have, quite a few questions going. But thank you so much for being so detailed about listing out the various symptoms, etc. It's extremely important for everybody to know when to raise a red flag and what are the red flags in daily living. Thank you, Doctor. Dr. Harish, let's move on to the next possible scenario, which is what are the complications that can be caused if PH is left untreated?
Yeah. Thank you, Mary, and thank you, Tua and MSN to raise this event for creating awareness about pulmonary hypertension. And as we all know, any disease that goes unnoticed and it leads to complications. And that's how I think if the pulmonary hypertension is not detected early, as Amit rightly said, it is often misdiagnosed or underdiagnosed because the symptoms that it presents with matches with many other disorders that the patient has. So breathlessness will be the predominant symptom which can be matched. So if it is missed and it is underdiagnosed or it is not diagnosed in the initial part of phase, it causes severe complications. We have patients who directly present with severe pulmonary hypertension, which is called irreversible pulmonary hypertension, where there is already a structural damage to the organs. So what happens in pulmonary arterial hypertension complications? The structures that are there prior to the pulmonary arteries, like the right ventricle, the right atrium, and there are structures behind that basically. So if the pulmonary hypertension is not being treated adequately or it is undiagnosed or it remains like that, then the first symptom the first complication I would like to tell is leads to heart failure. Because there is back pressure changes in the right ventricle has to create a lot of pressure to pump against the resistance. In doing so, the right ventricle elasticity goes for a toss. Elasticity of the compliance of the right ventricle is a very important phenomena to balance the pumping of the heart, the pumping of the blood to the pulmonary circulation so that it gets purified. All the deoxygenated blood comes to right ventricle, then it throws the blood to the lungs to get oxygenated. So what happens if the right ventricle is suffering? The blood that should be adequately sent to lung for purification process hampers. And when the right heart failure happens, the complications and the symptoms, as Amit rightly said, breathing difficulty, pedal edema, and all those symptoms, they start happening. In addition to that, when the right ventricle compliance goes down, it leads to back pressure to the right atrium. And when the atrial dimensions changes, it can lead in a complications in the form of arrhythmia. So what is arrhythmia is basically an irregular heart rate wherein patients get the symptoms of palpitations. And these arrhythmias, if not detected in time, can be very fatal. So many a times patient directly presents with arrhythmia, and when you try to dig into the cause of its arrhythmia, then pulmonary hypertension can be found in the cause of arrhythmia. Also, if the pulmonary arterial hypertension is uncontrolled and it is excessive in nature, the patient can have bleeding, which can present as hemoptysis, basically bleeding while they cough out the phlegm, and complications associated with that. So there are many complications when it leads to a stage where it is called as irreversible in our language, where there is permanent organ damage in the form of damage to the structure of the arterioles or damage to the right ventricular wall or strain on the right ventricular wall. The complications are still further, and they can be permanent in patients, leading to further complications. So I would like to summarize these complications as heart failure, arrhythmia, bleeding complications, and other things also.
Thank you, Dr. Harish. Dr. Kalmat, now that we have kind of discussed what to look for and what the symptoms are, could you tell us how it's diagnosed? Medically, what are the tests that you would recommend probably to diagnose this disease?
Yeah, Mary, that's a very good thing. And like it's very, like we started that diagnosing a essential hypertension, the regular hypertension on the left side is very simple by measuring the blood pressure on a by sphygmomanometer or a nowadays the electronic devices, and so simple that requires only 1 or 2 small visits by. But unlike all my colleagues were telling, I would like to impress a very important thing to the whole mass here, even the non-doctors or even the MBBS, the practitioners, the MDs, that saying that whenever the patient has undue breathlessness or tachycardia, we call that means his ECG is normal, X-ray is relatively normal, and even the echo is normal in the beginning part. What do you mean? See that when the patient has undue breathlessness without any reason, means he doesn't have a valve disorder, he doesn't have a congenital disorder, there is no, whenever these patients, in fact, many of the patients of chronic pulmonary embolism, that is small clots going to lungs causing pulmonary hypertension, is one of the important thing because it's a treatable thing, which in fact a lot of people, because I have had a few young individuals, unfortunately have 35, 40 years, had a very bad pulmonary hypertension because the small clots were going from the legs to the pulmonary arteries, which was not diagnosed. The only problem was the heart rate is 120, 110. So what I want to tell the mass is that when there is a tachycardia, a higher heart rate, and there is no explainable cause, the ECG looks normal, X-ray normal, echo is relatively normal initially, then please suspect pulmonary hypertension. That means the simple ECG is an important thing to look at the RV forces we call in the ECG, and an X-ray you could see a pulmonary artery dilated is important. But these are all very gross. But most important is to diagnose by a 2D echo and a color Doppler looking at the pulmonary arteries. A very important tool. In fact, I would many of my physicians friends are also learned that how to do it, because looking at the pulmonary artery pressures by looking at the TR jet or the pulmonary pressure time, we call them, they know it, how to diagnose it. If you can pick up a pulmonary hypertension on the echo, and sometimes it's so amazing that even the echo doesn't pick up, then we have a CT angiography or angiography, CT scan, angiography of the pulmonary arteries and the other vessels that can diagnose. And sometimes when you have really are not able to diagnose, even after all these 4 tests, you are not able to diagnose, then we look at ventilation perfusion scans or PFTs, and then do sometimes cardiac MRIs. And at the last, we do right heart pressure, right heart catheterization, looking at the RV, PA and PA end diastolic pressures to diagnose pulmonary vascular resistance. Is very, very important when then the patient is finally diagnosed. So in summarizing, the ECG, X-ray, echo are fundamental, followed by looking at the CT scan, MRI, ventilation scans, and right heart catheter. These are very important, Mary.
Thank you, Dr. Karmat. Dr. Kunal, if somebody gets PH and the conditions get worse over time, does it come to mind that this disease is fatal? I mean, that's a really tough word to use right now, but is there that kind of a possibility? Doctor, you're on mute, please.
Basically, pulmonary arterial hypertension is cured and treatable if we know the cause of that. If you don't find the cause, means there's an idiopathic, then the primary pulmonary hypertension is very difficult to treat. As my all colleagues suggested, during COVID time, we had very thrombotic events. Young people used to come with breathlessness, and when we used to scan, we used to just feel RA and RV is little bit dilated, but the pulmonary pressures were around 50, 60. So we used to treat them with clot dissolving drugs, that is thrombolytics, and patient used to do well. After 2-3 days, the pulmonary pressure comes back to the normal. And such case in chronic thrombotic pulmonary embolic disorders, again we have to do the VQ scan, and if we do the surgery, the patients do well. I had 3-4 patients which after CTPH were operated. Now the pulmonary pressures are very minimal, around 30-35. So they do good. But first we should find the actual etiology why there is a pulmonary arterial hypertension. If there is a sleep disorder, if we give them overnight BiPAP, they will definitely improve. If there is COPD, we should treat that COPD aggressively with a minimal amount of diuretic, that is a drug which increases the amount of urine. So with this drug, they can be little bit symptomatically benefited. So first of all, we should find the cause of the pulmonary hypertension and treat it. It's not that pulmonary hypertension means fatal. Yeah, primary pulmonary arterial hypertension is very difficult to treat and it has its own course of disease. But other pulmonary arterial hypertension we can treat. If it is a valvular heart disease like mitral stenosis, if the mitral valve is choked, if we do a BMV or if you repair it, the pulmonary arterial hypertension gets reversed. Or if there is a left ventricular disease, means first we have to treat the disease, the primary thing, and definitely the pulmonary arterial hypertension improves. I hope all are agreeing with me with this.
Thank you, Dr. Kunal. Dr. Alpa, I'm coming to you with another question, which is that I think somewhere there are some statistics saying that more women than men are affected by pulmonary hypertension. So in which case, what's the deal with pregnancy for women? Are they permitted to get pregnant?
Yes, so yes, very important question. And many of our patients want to know about this. So we just discussed the different causes of pulmonary hypertension. So out of that, the heritable one or the primary pulmonary hypertension definitely is more common in women, and that too in younger women of childbearing age. So this is a very important question. So what happens is that there is no general rule, but you have to know whether the pulmonary hypertension is mild, moderate, or severe. If it's mild, say pulmonary pressures are below 40, or in the moderate range, say about 55, and then it gets controlled with medication, then yes, pregnancy can still be possible. But there is always a possibility that during pregnancy, you are putting that extra physiological stress on your system, which is already working at half its strength. Definitely, the risk of worsening of pulmonary hypertension or getting a right heart failure is there, and that has to be discussed, that has to be explained, and then we have to take all the supportive measures, and then one can go ahead with pregnancy. But somebody who has got severe pulmonary hypertension and in spite of treatment, it is not getting controlled. He already had one child, and or somebody is, even if the is not there, but if the pulmonary hypertension is severe, then by and large, explain and counsel this patient, and it's better that pregnancy is avoided, because in this scenario, pregnancy can even be life-threatening. And in fact, it so happens, as many of my colleagues would also agree, that many a time, first time pulmonary hypertension is diagnosed after pregnancy, because does not get diagnosed before because the symptoms are non-specific and mild, and after pregnancy unknowingly they get, and during pregnancy the pulmonary hypertension gets exacerbated and then we end up diagnosed. So this is our
but doctor, I also wanted to just discuss this particular, it's like the social connotations of advising a woman not to get pregnant. I'm sure it is impacting the entire family, and therefore there might be, additional ripples of unrest in the family.
It does happen, but it's we have to balance between the medical side and the emotional side. Unknowingly, when this happens and people don't listen either, or when they don't know and they land up with pregnancy, then they face a lot of complication, not only for the patient but also for the child also. And so there are other ways of adoptions or going for surrogacy, and those things can definitely be tried.
Mary, I just want to add there to Alpa's that what the common people think is they're talking about moderate to severe pulmonary hypertension. Those people cannot ever become pregnant because the pregnancy is such a huge stress on the on the whole circulation, that then they can't bear it. Usually sudden death of mother and child is very common, and more than 50 to 70% mortality is seen in severe primary pulmonary hypertension in mother and child. That's why you should not allow them to become pregnant.
Yes, and that's why I was saying perhaps that's why they also won't reveal or they won't listen to the doctors because of the social pressures as well, especially in the
Yeah.
rural areas. Unfortunate, but a reality,
Yeah,
especially
but
in
in this scenario, we always advise that once the patient gets diagnosed, it would be good to be under treatment for good 6 to 12 months, bring the pulmonary pressure down, and then plan for pregnancy in mild to moderate cases.
Super. Thank you, Dr. Alba. Dr. Amit, my next question is to you. Is there any, from any perspective, do we believe or are there lifestyle changes that can be implemented by which we can avoid uh, getting a disease like pulmonary hypertension?
Well, Mary, as everybody has said that it all depends. It firstly depends on the cause of pulmonary artery hypertension. Once you understand the cause, if it is a cause that has been diagnosed to be caused because of heredity or because of congenital issues or because of certain diseases that cannot be avoided, then there is nothing we per se can do about it. But then there are other reasons for it, like lung diseases or heart diseases, or sleep apnea, or sometimes drug-induced pulmonary hypertension. These are something that we can avoid. So, and the understanding of lifestyle changes goes as it goes for all of these diseases. For lung diseases, your habits, your lifestyle, quality of life, improvement, your exercise is very important. When it comes to heart diseases, similarly, your diet, the amount of the quality of food that you're using or you're eating, and the exercise that you're doing, keep yourself fitter. Same goes with sleep apnea. Sleep apnea is a disease most likely in obese patients. So obesity is the main cause, and the consequential understanding of the cause is a pulmonary hypertension. So eventually, if you treat the cause, or eventually if you treat the factors that cause that cause, you automatically do not end up having a hypertension or a pulmonary hypertension in your life. But nevertheless, if you do get pulmonary hypertension, I think some factors we should all remember. Keep your blood pressures or keep your pressures in check. That is, keep your salt intakes as minimal as possible. Avoid having a lot of fluid in your body. So avoid drinking a lot of fluid. Keep yourself nausea free. That means acidities and nausea related factors can affect pulmonary hypertension if you have it. And make sure you're well nutrition, means specifically iron. Low iron is sometimes related to pulmonary hypertension. And also, most important of all would be exercise. A more mild to moderate exercise if a patient is of pulmonary hypertension, according to what their doctors have prescribed them. And sometimes if a patient has a lung disease, then pulmonary rehabilitation is a very important factor to improve the quality of life of a patient with PH, or also to avoid PH.
Thank you, Doctor. Dr. Harish, we believe we've put Corona behind us, COVID behind us, although it still seems to be lurking here and there. Do you think that post-COVID, the incidence of pulmonary hypertension among your patients has gone up?
Yeah. So as we have battled through three waves, basically fourth wave or whatever, still we are hovering around with cases coming bits and pieces. But as we all know, the scarring that viral pneumonia due to COVID causes, it leads to some form of interstitial lung disease. Though the incidence of number of cases that are returning back after severe COVID in the form of interstitial lung disease are not so much. But still, interstitial lung disease or fibrosis of the lung is definitely a bigger challenge because it causes severe pulmonary hypertension. So I would definitely say that COVID-related viral pneumonia, when people suffered a severe form of pneumonia, they had scars in the lung in the form of fibrosis, and then it has definitely led to increase in the incidence of pulmonary hypertension as it was previous to the COVID pandemic. Also, as discussed previously, also COVID-19 was a pro-thrombotic state. That means it was a state where there was more chances of getting clots in your body. So during our experience of COVID-19 in global hospital, we had faced a lot of challenges wherein the patient directly had a pulmonary embolism type of situation wherein the clot has got stuck in the vessels of the circulation of the lung, and the patient presented directly symptoms of pulmonary embolism. So, and the clot that the COVID-19 virus created, it was such a tough clot to dissolve, because I had 2-3 cases wherein we had given the optimal form of treatment recommended for dissolving the clot, but still it never buzzed off. And we had very huge fatal outcomes in patients who had pulmonary embolism, which were battling with COVID-19. So I would definitely say because COVID-19 leads to scarring of the lungs and formation of interstitial lung disease, and also as it was a prothrombotic state with leading to pulmonary embolism or small emboli here and there, definitely led to increase in the incidence of pulmonary hypertension that was there prior to this COVID-19.
Thank you, doctor. In fact, that's a good reiteration for everybody and a good reminder to be careful, not just about contracting COVID once more, but also to remember all the COVID episodes and monitor it. Dr. Kalmat, my next question is to you. Where today in a generation that stops for no one, that waits for nothing, and so everybody is on the move, everybody is always up and about, traveling, for whatever reason, could you help us understand, for patients who need to travel for work and business, and if they're suffering from pulmonary hypertension, what is the kind of advice that you would like to give them?
That's a very good question. And to add, Dr. Harish very nicely told earlier, we thought the COVID was causing ARDS and death. Actually, that was one of the cause. We used to have death, but when we realized within a few months that it was a pulmonary microvascular obstruction, and pulmonary embolism was the major cause of death of these patients. So that's why the antithrombotics like rivaroxaban and heparins, and which was very, very widely used in these patients, made the mortality lesser and lesser. So that's a small addition to that. So very beautifully you put it. We are talking only about people who have more than moderate pulmonary hypertension. Mild people, no restriction, mild to moderate. And mild to moderate are generally due to some reversible causes of sleep apnea, obesity, left heart disorders, valve disorders. Those people usually, whenever there's a correction of the heart disorder, the pulmonary hypertension comes down. There's a beauty of that. In fact, the highest pulmonary hypertension you see in mitral stenosis, young ladies in India who are still, it's not gone, rheumatic mitral stenosis, very severe narrowing of the left valve, have pulmonary hypertension of 120/30, which can melt like a butter when you do a balloon mitral otomy, which we do, intervention, we do that, and the hypertension comes down from 120 to 40s and 30s, and like that's one thing which is where the reversible causes. The reversible causes are the heart disorders, and some of the lung disorders like Alpa told you, and then some of the drug users, and chronic embolism, and we do an embolectomy for these patients. And it's a very difficult surgery, but some of the surgeons are doing, like Kunal was telling you, these can be done. So you should be very aware of trying to find out, is there any treatable cause for pulmonary hypertension, which is predominantly large, luckily. Unlike in the essential hypertension, there's only 8 to 10% have got secondary hypertension due to coarctation, pregnancy, or other disorders like kidney disorders. Here, there are much more treatable pulmonary hypertension patients, and the primary pulmonary hypertension are relatively small, which will be dealt by Dr. Kunal and Dr. Alpa, and they will tell you about how to treat that. Before I sign off, because I had rushed for the meeting, your question was that how to treat, how you allow them to travel. Well, you have to check their oxygen saturation. If it is less than 92 or 90, then they need to carry oxygen with them, and they go to, you should avoid them to have a long distance travel or a high altitude travel, because high altitude, the oxygen saturation is less. You should not allow them to go there, number one. Number two, if they travel long distance, they should be moving the legs. They should have, sometimes you have subcutaneous heparin, they should take it and travel long distance, more than 8, 10, 12 hours in a flight or something like that. And also if they are oxygen saturation is less than 90 or 92, they should have oxygen supply with small cylinders nowadays portable also, and also they should take care of hydration, which is very important for them. These are the gross, smaller things which I'm going to tell you about the travel part. And as I just told you about the long-term care of these people, and to certainly look at the reversible causes or many of the causes, as we said, heart disorders, congenital heart disorders, sleep apneas, which can be beautifully treated by a CPAP machine, which they will tell you in a few minutes time. I think, Mary, that puts a lot of truth. Thank you.
Just want to add one thing here, that when these patients are traveling, it's very important to have them evaluated before they take up any travel. And when they're taking any leisure travel, it's very important to make them realize that they should not be doing any activity that will become a physical exertion. So that's very important, because that's where when exert physically when you are out, on a vacation, and then you'll end up having complications.
What Alpa is saying is that when there's a severe hypertension, you cannot take undue like recreational activity, like you are trying to go for a very long swim, or you are going for a very huge recreational activity which you physically tired. That cannot be done for these severe hypertension patients.
Well taken on board. The point is indeed extremely valid, especially the fact that even when you travel, you can't forget that you're carrying with you this kind of a disadvantage, but there's no need to exacerbate it and make it worse. Thank you so much, Dr. Kalmat. Dr. Kalmat, will you have to leave now, or will you be able to wait? You're on mute, doctor.
If I leave in a few minutes, is it okay, or you want me to?
No, there's no problem if you have an emergency. Otherwise, we'd be happy to have you until the end.
Thank you. I'll try another few minutes. I'll let you. Thank you.
Thank you so much. Thank you, doctor. Let's move on now. Dr. Kunal, my next question is, since we have talked now about the causes and things like that, could you shed some light on what's the new treatment modalities and technological advancements that patients can look forward to?
So basically now in this new advances, I will just talk about primary pulmonary hypertension. As I first spoke, we should treat the cause. Secondary causes that everybody told, COPD, might be a COPD, might be a sleep apnea, or a congenital heart disease, or rheumatic heart disease, or left ventricular disease. We should treat that. The pulmonary artery pressures get also treated. And a small dose of diuretic, which I already mentioned. Now coming back to primary pulmonary hypertension, previously we used to do vasoreactive testing in the cath lab, and we used to give, if they are responsible, we have to give calcium channel blockers. Now in our armory, there are endothelial receptor blockers like bosentan, ambrisentan. There are new drug called as macitentan has also come in the market, 10 mg, which we can start among the patients. Then there are also phosphodiesterase inhibitors like sildenafil, tadalafil. There is a combination. So in pulmonary hypertension, we should give combination drugs which acts at different pathway so as to block the pathway of the pathogenesis, and we can get a maximum benefit to the patients. There is one new drug which is called Reoseogod, as well as prostacyclin analog, that is a oral tablet, Selexipag, which is also now available in India, which we can give for primary pulmonary hypertension. And this is about the medical management. There is one intervention which we can do in severe pulmonary hypertension or a refractory pulmonary hypertension is a balloon atrial septostomy. Means here we will create a hole in the heart, in the upper part, that is atrium in the heart, so that the right side of the heart gets decompressed into the left and increase the cardiac output. This is called as a balloon atrial septostomy. And the last is lung transplantation, which is also it's the last modality in primary pulmonary hypertension. Dr. Harish sir can enlighten us about his experience with lung transplant.
Indeed, Dr. Harish, that's not even part of the script, but I think it's essential for us to share this with our listeners and followers. So please do shed some light on that.
So as Kunal rightly said, when it comes to primary pulmonary hypertension, or when it becomes a very severe, irreversible pulmonary hypertension, where I previously mentioned that you get a structural damage. After the structures getting damaged, like the arterioles getting thickened, no drug or no therapy would work. And then in that case, the patient becomes oxygen dependent, sedentary, bedridden at one place. So the only answer to this question is basically doing a lung transplant if the cause of the pulmonary hypertension is an interstitial lung disease predominantly, or if it's a primary pulmonary hypertension and lung condition associated with that, then the heart and the lung transplant both needs to be replaced, because once the vasculature becomes irreversibly damaged, just doing a lung transplant will definitely will not help in these patients. So we have done heart and lung combined transplant in global as well as bilateral lung transplants also. And if the patient is young, there are no other comorbidities, like there are no other organ involvement, the kidneys are okay, other things are okay, then definitely this is a treatable option, particularly for younger patients, I would say 45, 50. After 65 and 70, it still becomes a very difficult challenge to handle. But the ultimate treatment for such irreversible pulmonary hypertension or primary pulmonary hypertension definitely will be a lung transplant or heart and lung.
Thank you, Doctor. Indeed, there is a lot of hope in that particular aspect. Dr. Alpa, can you tell us, are there any other supportive therapies for pulmonary hypertension? Dr. Alpa, you're on mute, please.
Yeah, a lot of it has already been discussed. So supportive care is very important. The moment somebody gets diagnosed with pulmonary hypertension, especially the primary pulmonary hypertension, people really go and find out, get a lot of information on Google, and they know about their prognosis, and they generally people will get depressed because they are very young. Then they have this disease. They get some half big information from different sources, and then they get very depressed. So when we have to support this patient, the support has to be at physical level, psychological, emotional level, and also at spiritual level. And that's very important. So many things, like say that if you've got a heritable pulmonary hypertension, primary pulmonary hypertension, or you have some advanced lung disease or heart disease, those things are not in your hand. But each and every patient, be it mild, moderate, or severe pulmonary hypertension, it is in their power to change the lifestyle, to change the supportive care. The first most important advice that we give is that we have communication with the patient, that this is the diagnosis and what can be done. And there is a need to change the lifestyle. So many times they have to change their work profile. They have to reduce their physical activity level. They change their the way they are working. So that one thing we have to advise. Second aspect is about the nutrition. So we definitely need to change the nutrition, like reducing the salt intake, having more antioxidants in their diet, avoiding a lot of processed foods. So all those, nutritional advice we give to them. And this has already been discussed, that reduce the fluid intake, reduce the salt intake, so that unnecessarily retention of fluid is avoided. And we have to treat the associated condition, like a patient already has got advanced pulmonary hypertension and develop heart failure. Then you have to treat by giving small dose of diuretics. We have to treat the associated condition. And it is pretty common to have pulmonary hypertension existing with other comorbidities, say like thyroid or diabetes or heart failure. And so all those comorbidities need to be treated, and usually we have team of doctors who will manage this patient together, and not single specialist managing this patient. And then the important aspect of physical activity, because sometimes the moment you get diagnosed with a disease which is not irreversible, you tend to reduce your physical activity, and that is something which should never be done. So physical activity should be encouraged. Not only that, a structured pulmonary rehabilitation program, and that's very important. And many of our patients, we no matter what may be the severity of pulmonary hypertension, but we enroll them for pulmonary rehabilitation, and it makes a huge difference in the type of activity they can do. And once they start to become more active, mobile, and more independent, it gives them a lot of psychological confidence. So pulmonary rehabilitation is a big boost to them physically as well as emotionally. Yoga and meditation also has been used. So I use a lot of yoga and meditation for my patient because I myself am a yoga practitioner and meditator, and I advise them. And so many a time patients are not able to actually come to the center and get the pulmonary rehabilitation done. But at their home, in whatever small way, they can start doing breathing exercise, yoga, simple asanas, and meditation. And that makes a big difference. If you can just reduce their heart rate, you can reduce their stress level. So that much lesser stress we are putting on the system. All these together along with counseling, and I think there is one very new thing that is developing in our country also and abroad. A lot of these patients with similar disease, they have support groups. People with similar condition and their relatives, they meet periodically either offline or online and discuss many things and exchange many good things. And that is, so in some places even in India now, that is started, and that is, I think, a way forward to create this kind of support system. And so I think it goes a long way in creating a good quality of life for a pulmonary hypertension patient.
I'm sure even support groups will be helpful for caregivers, because
Absolutely,
to understand and to be able to do the needful and also keep their own positivity and hopes up all the time. Dr. Amit, it's a simple question really. Perhaps, I don't know how it will come across, but is PH curable?
Well, at the risk of not sounding very repetitive, again, well, in a simpler answer, I would say yes. But there's always a but on these conditions. There are exceptions on that and that cause. So again, the exceptions all depend on what the cause of PH is. Like many of my seniors have said here, Dr. Kalmat said that there is something, for example, in a severe mitral stenosis patient, right? That is a basically a cardiac condition. If there is a balloonoplasty done or a valve replacement done, you can suddenly change the patient's condition from severe PH to absolutely no PH. Similarly, there are many such conditions that are reversible, as we call it. Thromboembolism could be a reversible condition. You remove the embolectomy or medical management, and your PH is gone forever. So there are certain causes that can be reversed completely if they are in that condition of reversibility. But unfortunately, there are also certain causes, for example, a COPD, for example, an ILD, or idiopathic, or even hereditary. These cannot be reversed. But fortunately enough, we can treat them very well. We can keep them in control, and this disease becomes like any other disease, which can be managed medically with lifestyle. For example, everybody knows about diabetes, which people think is it is a treatable disease. That means it can be controlled very well with medications and lifestyle modifications. Similarly, a PAH can be treated and controlled very well with medications and lifestyle modifications, both going hand to hand together. And pulmonary hypertension, pulmonary rehabilitation, as Dr. Dalal also explained. So there are many ways to control it for sure.
Thank you, Doctor.
To add here, if you may allow me that, so many times what happens that we get stuck on the numbers and we keep asking that, oh, is it curable? Is it curable? But I think more than just, for patients to just focus on the numbers, it's just they have to see that how much better they are feeling, how much better they are able to do their activities, and how their symptoms are in control. So just by, monitoring the serial numbers of pulmonary, all are very important for them to consider.
Absolutely.
Yeah. And also to just add one point to this, as Dr. Dalal said, that it is not just the medications only. Very important to remember to all the patients that the everything that we spoke about, the supportive therapy, like the diet intake and the nutrition, everything, these things matter a lot. The exercise pattern, the pulmonary rehabilitation, even the yoga, for example, these things really improve the quality of life of the patient if it is done consistently and for a good amount of time.
In fact, sometimes our patients surprise us where we see the numbers is like 80 and 90, and the kind of activities, the kind of life they are dealing, So, we also get surprised with this kind of numbers. And then we realize as medicos also that apart from medication and, prognosis just based on the numbers, their mindset plays a big, big role in improving their prognosis.
Absolutely. And I think that's where it's more important when the patients themselves address their issues positively and take it forward. Dr. Harish, I'm going to wind up my questions with a last question to you, which is, could you tell us a little bit, just touch upon the topic of PH and sleep apnea and what's the connect? But I have one more set to this question, which is that can you help us understand the role of vaccinations in the management of PH as well? So we'll start with sleep apnea, though.
Yeah. So we'll take the first part of the question in sleep apnea. As you all know, sleep apnea is a disorder which is there in many patients who has uncontrolled diabetes, uncontrolled hypertension, or those patients who keep on getting recurrent stroke or heart attack. The sole cause of all this is sleep apnea in many of the patients, which is underdiagnosed, which is undetected. But now, as the awareness of sleep apnea has increased post death of Bappi Lahiri, everybody knows Bappi Lahiri had a very severe sleep apnea and he died because of that same. So actually, why pulmonary hypertension develops, basically, it's a vasoconstriction, basically. The vessels, the pulmonary arteries, they go into vasospasm. And if they remain in the same position for long, it leads to development of pulmonary hypertension. And why this vasospasm happens is a natural phenomena of reaction to hypoxemia. That is when the blood level, oxygen levels in the blood go down, the vessels in the pulmonary circulation, they go into spasm. That's a natural phenomenon. That's a natural way body handles the ventilation and perfusion to give adequate oxygenation to oneself. So what happens in sleep apnea, once the patient goes to sleep and he gets episodes of hypoapnea and apneas, wherein the breathing stops for a while. In apnea, it is complete cessation, whereas in hypoapnea, it is partial cessation of breathing during the sleep. The oxygen level keeps on going down. And you will be amazed that when I done sleep study of several patients who were sounding symptomatic with a loud snoring symptoms of increased daytime sleepiness, symptoms of increase in the weight. Recent increase in the weight is another symptom where somebody can come with a increase in the waist circumference from 32 to 40 directly in few months. So what happens in these patients, basically, the oxygen level keeps on going down. And when you do a sleep study where the oximetry is monitored, I have seen patients having saturation of less than 50% for more than 10 minutes in the sleep. So when this phenomena keeps on happening back and forth every night, it gets unnoticed by the patient because nobody is monitoring, nobody is trying to find out that there's a root cause for diabetes, root cause for uncontrolled hypertension. So once this oxygen level keeps on going down for several nights together, as I explained, because of less oxygen in the circulation, the pulmonary circulation goes into vasospasm. And these patients eventually develop pulmonary hypertension. Many of patients, they directly present to you with pulmonary hypertension. And when you dig into the history, dig into the details of the patient, you find that sleep apnea is the cause of pulmonary hypertension. And for diagnosing sleep apnea, you need to do a sleep study test called polysomnography, wherein we put electrodes across the patient to monitor the oxygen level drop during the sleep. And there are several other parameters, apnea, hypopnea index, and other indices, which will tell you about the severity of the sleep apnea. And it directly gets correlated with pulmonary hypertension. And as rightly discussed by other panel members also, it is the reversible cause of pulmonary hypertension. If you detect a sleep apnea and you detect a pulmonary hypertension, you treat the sleep apnea adequately by changing the lifestyle of the patient, is causing weight loss of the patient. Also, if you start putting across the auto CPAP or a BiPAP, whatever is required as per the requirement of the patient, you reduce the airway resistance that happens during sleep that creates a snoring sound. And eventually what you do is reduce the oxygen drop which happens in the sleep. Once the cause for the vasoconstriction, as I explained, hypoxemia, it gets treated, the pulmonary hypertension reverses slowly back to normal. So this is the correlation of sleep and sleep apnea and pulmonary hypertension. And I think everyone who assesses the patient for pulmonary hypertension will definitely go into the digging of the history and doing a sleep study if appropriate and finding out the cause. Coming to the second part of the question, where role of vaccine in treatment management of pulmonary hypertension. Definitely, vaccines definitely will prevent, as we all are aware of COVID-19 vaccination, which has definitely prevented a severe form of COVID-19 in many patients. Other vaccines like influenza and pneumococcal vaccine, these are the vaccines which are supposed to be taken. Definitely, every patient who has severe lung disease like a COPD, chronic bronchial asthma, or a patient who has interstitial lung disease like fibrosis of the lung, all these patients who have chronic lung disorders, if they vaccinate themselves regularly as recommended by the physician, chest physician, then they can prevent happening of pneumonia episodes or exacerbation of the underlying disease. So in turn, basically, these episodes will lead to development of pulmonary hypertension. So if you indirectly correlate basically prevention of pneumonia, and pneumonia, if it sets in and causes permanent damage to the lungs, or if the patient has recurrent exacerbation of interstitial lung disease because of pneumonia. So by preventing these episodes, you are definitely going to prevent exacerbation of pulmonary hypertension or development of pulmonary hypertension in this patient. And also, recently there was a detailed work in developing vaccines which will help prevent the remodeling of the pulmonary circulation in the right ventricle. And endothelin A receptor antibodies they have created actually. And if you vaccinate these people with these antibodies, then the remodeling for the pulmonary artery and the right ventricular, which is a bigger concern whenever the pulmonary hypertension goes to a very severe form, can be prevented. So these are the two vaccines I would say. Preventing pneumonia vaccines and the vaccine again, endothelin A receptors will definitely help in management of pulmonary.
Thank you, Doctor. In fact, I think today has been an extremely enlightening day because there's a lot of information that has been shared, a lot of new terminologies that we have heard, and that help us to understand a little better what pulmonary hypertension is, who can get it, how to handle it. And I think that's all the reasons why we should be meeting our doctors at the right time to get the right kind of advice, treatment, and therefore to get the right way of leading a longer and happier quality of life. On behalf of Times of India and Emerson Laboratories, I would like to thank all the doctors here, Dr. B.C. Kalmat, Dr. Kunal Sinkar, Dr. Alpa Dalal, Dr. Amit Gawande, and Dr. Harish Chaple. Thank you so much for joining us today, for enlightening us, for sparing your time, and for making sure that the world is a healthier and happier place thanks to your care and intervention. Thank you and God bless. Have a good evening.
Thank you.
Thank you.
Thank you. Thank you very much.